السلام عليكم ورحمة الله وبركاته. دكتور، السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله تعالى.
دكتور اخبارك؟ ان شاء الله بخير.
والله الحمد لله طيبين.
يعطيك العافية.
طيب احنا نعمل فيديو ولا اوديو فقط؟
لا خلينا على الاوديو دكتور، بس عشان ما يصير في كاتنج اثناء.
طيب لانه هن عاملين له فيديو الان.
ممكن تعمل كت الفيديو.
اعمل ستوب الفيديو.
انا اعمل لك ستوب الفيديو. اوكي نو.
اعمل ستوب. اوكي.
alright fine.
اوكي ستوب.
alright still.
تمام.
Yeah, you can share your screen now.
No.
The first slide please. دكتور. First slide.
ما عارف ما داري اشتغل ليش.
ممكن تعمل backward. إذا رحت بالماوس على تحت آخر الشاشة، أنزل الشاشة آخر حاجة دكتور.
اوكي.
حتلاقي فيه سهمين، واحد في طيب السلام عليكم ورحمة الله وبركاته. حياكم الله في ويبنار بموضوع جديد. اليوم حيكون معنا الدكتور حامد طاهر، استشاري أمراض نساء وولادة. أمراض نساء وولادة حيكون معنا من مجمع الملك فيصل الطبي، ممثلة بمستشفى النساء والولادة إن شاء الله. حيكون معنا بموضوع جديد اللي هو الإجهاض المتكرر. تفضل دكتور، المايك معك.
اوكي ثانك يو، شكرا لك استاذ طارق، كثر الله خيرك وبارك الله فيك. اوكي، بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Okay, today we are going to talk about a very important topic that it is a devastating problem for all women, and it is psychological depression for all women. And this is recurrent miscarriage or recurrent pregnancy loss. Okay, first of all, we are going for introduction. We are going to see what is the meaning of spontaneous abortion, what is the meaning of recurrent miscarriage, and different school names for this recurrent miscarriage. Then we are proceed to causes of this recurrent miscarriage. We have a lot of causes, which include one of them are strongly correlated to recurrent miscarriage, other are poorly correlated to recurrent miscarriage, and the other is unexplained. Then we are going to evaluate the patient from history, examination, investigation, and then treatment. And at the last, we are going to conclude our talk. Okay, definitions. What is the meaning of miscarriage? Miscarriage meaning is losses of pregnancy before the fetal viability. It has a different term because of viability. Some people, they said 24, this is RCOG, Canadian 28, and USA 20, WHO 22. And include all pregnancy losses from time of conception till 24 weeks. This is RCOG. Ectopic molar pregnancy are excluded. And now, what is incidence of spontaneous pregnancy loss? It depends on the population's study, and it will be between 17 and 20. And in UK and USA, it's up to 30% of population have spontaneous miscarriage. From this, recurrent miscarriage is only 1 to 2%. Okay, recurrent miscarriage, we have two schools definitions. One of them is RCOG. It said that recurrent miscarriage, it is 3 or more consecutive pregnancy losses. These losses started from, when pregnancy is confirmed. It is not biochemical pregnancy, it's confirmed there is intrauterine gestational sac till 24 weeks. The other thing is American Society of Reproductive. They said recurrent miscarriage is definitions 2 or more pregnancy losses. This here pregnancy it started from when pregnancy test is positive. This is the difference between the two definitions. Then we are proceed to the causes. As I said, we have possible causes. This includes anatomical, okay, neurological, infections, okay, thrombophilia, and antiphospholipid syndrome, and we have doubtful causes. Possible causes has strong correlation to the cause of recurrent miscarriage. Doubtful, they have weak or poor correlation to the cause of recurrent miscarriage. But unexplained, the majority of the causes is unexplained that can exceed up to 50%. They have no cause, and okay, the pregnancy rate in these people or a live pregnancy outcome is higher with this unexplained pregnancy losses. Okay, this is just a diagram that show us the causes of pregnancy losses. As I said, okay, we have strong correlation, and these genetic factors, the majority of them are unexplained, okay, which can be up to 50%. We have endocrine factors up to 20%, and we have autoimmune factors up to 20%, anatomical factor 10-15%, then genetic factors that can due to fetus factors and paternal factors, and at least is infection that is so less we have. Okay, possible causes, as I said, is have strong correlation between the causes and miscarriage. My voice is okay or not? Okay. Anatomical factors, it take up to 10% of all causes of possible causes of miscarriage, and this included congenital uterine malformations, septated uterus, conjugated uterus, and arcuate uterus, and submucous fibroids. That fibroid can be pendulated in the uterine cavity, cervical insufficiency, and severe intrauterine adhesions due to multiple surgical intervention or infection. Okay, the second part of possible causes is endocrine. Endocrine diabetic control is not cause of recurrent pregnancy loss, but uncontrolled diabetic that can cause recurrent pregnancy. The same, uncontrolled thyroid disorder can cause recurrent pregnancy loss, but controlled thyroid disease have nothing to do with recurrent pregnancy loss. Okay, infections. We have only two. Other screening for torch screen, no need. We have only two need to screen for Brucella and bacterial vaginosis. Brucella have a lot of causes of pregnancy, has major cause in pregnancy loss due to abortion, IFD, or early pregnancy losses. And bacterial vaginosis has a good correlations with early or second trimester miscarriages. Okay, antiphospholipid antibody syndrome and inherited thrombophilia defect, factor V leading, prothrombin mutation, and protein S deficiency. And we have genetic factors, parental chromosomal abnormality, or this is about 2 to 5% of recurrent miscarriage, and embryonic chromosomal abnormality, unbalanced translocation, which can be up to 30 to 50% of further cause of genetic causes. Paternal chromosomal abnormality is unbalanced translocation. It is about 2 to 5%. Any patient with unbalanced translocation or parent with unbalanced translocation need to see further genetic evaluation for them. Brucella and pregnancy outcome, as I said, it's high rate of abortion, preterm labor, and IFD. Of course, of spontaneous abortion and IFD, it is due to toxemia, maternal bacteremia, acute febrile reaction, DIC. We can diagnose this by titers. in endemic area or non-endemic area, as we see. The disease may persist as relapse or chronic or localized infection or delay convalescence. Bacterial vaginosis, as I said, it is a risk factor for preterm labors, and it is already as screening test in RCOG, and it is mandatory in patient with history of preterm labor and second trimester miscarriage to do swab and to see what about screening tests during pregnancy in high-risk women with previous history of second trimester miscarriage or preterm labor. As we see here, all my reference is written down to the line I said. Okay, the doubtful causes or the causes with weak correlation between the cause and miscarriage. We have local, okay, and we have systemic, and then we have infection, okay. We are go back to local causes, okay. Local causes include oocytes from the woman, sperm from the male, and embryo, it is fertilization, and the endometrium, the recipient. Oocytes or premature ovarian aging reduce oocyte quality and quantity, and it causes recurrent pregnancy loss because the quantity of chromosomal material is not good, and that can cause recurrent pregnancy loss. Sperm, it is due to paternal causes, and there is causes of DNA fragmentation. This can cause chromosomal abnormality in the man, and then from there, insufficient fertilization of the ovum. Embryo, okay, improves the prognosis in recurrent miscarriage if we did ART and pre-implantation genetic diagnosis for aneuploidy in women with unexplained recurrent miscarriage. This improves the pregnancy rate, okay, only in patients with unexplained. Endometrium, normal endometrium can distinguish between good quality and poor quality embryo. Okay, as I said, sperm DNA fragmentation significantly increased recurrent pregnancy miscarriage, recurrent miscarriage. 85% of unexplained recurrent miscarriage. And how we screen for this? We do something called DNA fragmentation index. If it is more than 30, male infertility. If it is between 30 and 15, it is cause of recurrent miscarriage. If it is less than 15, excellent to good fertility potential. Okay, systemic factor. This is second factor in doubtful causes. We have anatomical, we have endocrines, and we have thrombophilia. Okay, anatomical, congenital acquired, okay, mild intrauterine adhesions and fibroma and polyp. Endocrines, we have polycystic endometriosis, luteal phase deficiency, hyperprolactinemia, and obesity. Thrombophilia, we have hyperhomocystinemia, protein C deficiency, and thrombin 3 deficiency. Infections, chronic endometritis, TORCH, not recommended to screen in pregnancy and recurrent pregnancy losses. No, we have to screen for toxoplasma, licomycin, Listeria monocytogen, Chlamydia trachomatis, herpes simplex virus, and CMV virus. This, the lower, okay, this need to screen for them. No other TORCH, no need to screen. Okay, chronic endometritis, we are going to do office hysteroscopy by immunohistopathology and high prevalence in recurrent pregnancy loss. They have high prevalence in 2016. Immunological, we have autoimmune antibody, like thyroid antibody. We have autoimmune factors, immune reaction against the mother. Environmental factor, alcohol, smoking, electromagnetic field, radiations, inhalation of anesthetic gases, exposure to the well, heavy material, and industrial. This all can cause recurrent miscarriage, no, with poor correlation. Okay, now we are going to evaluate the patient to take good history and then examination and investigation, and this will help in the plan of the treatment. Okay. First of all, we are going to take obstetric history from the patient. Then we are going to take surgical, medical history. I will show you surgical, menstrual history, family history, because every genetic problem can, environmental history, arterial thrombosis or venous history. Previous investigation, we are asking the patient if she has imaging histopathology or something like that. Obstetric history, we are going to talk about, to ask about the gestation age when she miscarried. Okay, and this will give us chromosomal and endocrine defect for first trimester, fetal heart, anatomical or immunological for second trimester, and there is overlap between them. Embryonic fetal cardiac activity, chromosomal abnormality, recurrent miscarriage period to detection of embryonic cardiac activity associated with when the baby have no fetal heart. Okay, surgical uterine instrumentation for adhesion. Just we will ask the patient if she had DNC, something like that. Okay, and then from there can take any infection. Menstrual irregularity cycle will give us about the endocrine, galacturia, hyperprolactinemia, and family history about previous recurrent miscarriage in family if they have, because this is related to genetic problems. Environmental, she had any radiological problems. Smoking, something like that, and venous or arterial thrombosis, which is associated with antiphospholipid antibody syndrome. Previous investigation, what she did, and we will take it from laboratory pathology or imaging, what she did. Okay, physical examination, we are going to examine the patient from up to down. We will look for sign of hirsutism, galacturia, then hirsutism, we are going to classify which type of hirsutism from up to down, if there is any milk from the breast, or we are going to assess her abdomen and then the pelvic organ, okay, to see for uterine malformation or cervical laceration. And it's difficult, this problem by examination. No, by imaging, we can found the uterine malformation. Investigation. First of all, we are going to see what is anatomical factors that cause the recurrent miscarriage. We are going to do initial screening test. It is simple. It is found in a hospital, and we can do it at office, like pelvic ultrasound or HCG or sonohysterography. Then, if we have doubt about that, we are going to definitive diagnosis, hysteroscopy, laparoscopy, or 3D ultrasound, or MRI. Then we are proceeding to investigation. We are investigating thyroid stimulating hormone, if she had any sign of hypothyroidism or hyperthyroidism. Okay, we are going to test thyroid stimulating hormone. I think no need to test about total thyroid, total T3 or 4. Infection, we are screening oral for Brucella and bacterial vaginosis. Antiphospholipid antibody. Okay, we are talking about lupus anticoagulant or anticoagulopin antibody or anti-B2 glycoprotein 1 antibody. If one of these tests is positive and apart 12 weeks, we are going to diagnose, and we need other clinical finding like recurrent miscarriage or thrombosis or arterial or venous. Then with this associated, we can diagnose the cause of recurrent miscarriage. Okay, thrombophilia, we screen for factor 5 feeding or factor 5 gene mutation, prothrombin deficiency. No need to screen for other like antithrombin 3 and protein C deficiency, only because correlation is poor and this correlation is high. Karyotyping, we are going to screen if patient she had recurrent miscarriage, more than 3 miscarriage. We are going to detect the product of conception of the third and subsequent consecutive miscarriage, and then we test it for chromosomal abnormality. If there is any abnormal in that one, we are going to proceed to screen for parents. Okay, from peripheral blood karyotype or best parent where testing of the product of constitutional report and unbalanced translocation. Chromosomal abnormality. يعني first we will do cytogenic analysis or chromosomal analysis of fetus product of conception. Then if it is positive, we are going to screen for the parent. Okay, this is the cause we finished, and now going to the treatment of the causes. Okay, treatment of possible causes have a high correlation with recurrent miscarriage. We have various anatomical, I said, congenital uterine malformation, uterine septum. This is just hysteroscopy resection of the septum, and the success rate is so high, and the pregnancy or live pregnancy rate is high with these procedures. Some mucosal fibroid, hysteroscopy, myomectomy, depend on the experience of the physician, and the success rate is also high. Severe intrauterine adhesions, hysteroscopic surgery, the same. Cervical incompetent or insufficiency, we are going to do cerclage for the patient with recurrent miscarriage if we have history of recurrent miscarriage, and we are doing cervical cerclage. Cervical length, if it is less than 2.5 or less, we are going to do cervical cerclage. Okay, this is some people from NICE guideline, from American, they said 1 or more second trimester miscarriage or preterm before 24 weeks to do TVS, then cervical is less, then we are proceeding cervical. 3 or more previous preterm or second trimester miscarriages. Okay, treatment of hypothyroidism, elastocin. This is our objective, to be thyroid stimulating hormone is less than 2.5, and doses depend pregnant or not pregnant lady, and like this patient, we are referring to endocrine stimulation. Okay, this is thyroid stimulating hormone level and thyroxine dose, how you increase it. If it is between 5 and 10, you are going to increase thyroxine dose to 25-50 microgram per day. Okay, if it is 10-20, you increasing 50 to 75 per microgram per day. If it is more than 20, it is better to refer to endocrinologist to manage this patient, and then after the level will be, it is 2.5 or less, then patient can try to get pregnant. Infection, as I said, we have 2 main causes of recurrent miscarriage, Brucella and bacterial vaginosis. About treatment of Brucella, if it is positive, okay, you are going to give rifampicin 900 milligrams once daily for 6 weeks, or 900 milligrams daily plus rifampicin. Trimethoprim, sulfamazole. Okay, asymptomatic abnormal vaginal flora and bacterial vaginosis. Oral clindamycin early in second trimesters, like 300 milligrams per ounce BID for 7 days. Significantly reduce the rate of late miscarriage, the second trimester miscarriage, and spontaneous preterm birth in general obstetric population. Evidence level 2. Okay. Antiphospholipid syndrome. If it's already diagnosed, we can give low dose aspirin plus heparin. This study showed that it reduced the miscarriage rate by more than 50%, no difference in efficacy and safety between unfractionated heparin and low molecular heparin was combined with aspirin. No, there is difference. I think difference in the efficacy mafi, not and safety between the unfractionated heparin and low molecular heparin, there is difference. Yeah, because unfractionated heparin, they can cause thrombocytopenia, they can cause, because what we are using low molecular heparin with combined with aspirin. Low dose aspirin, no adverse fetal outcome, and heparin, no adverse fetal outcome. This is definitive treatment for patient with antiphospholipid syndrome. No need to give any patient low dose aspirin or heparin without evidence of antiphospholipid syndrome. Inherited thrombophilia, we are treated with low molecular weight heparin. Recurrent miscarriage in first trimester, insufficient evidence may improve live birth rate for this woman. يعني أي first trimester miscarriages, no need to start heparin. في second trimester, improve the live birth rate. From this one, like I said, in inherited thrombophilia, we can start heparin in patient with a recurrent second trimester miscarriage. No, with first recurrent first trimester miscarriage, ما في evidence to show us improve a live birth rate. Okay, genetic factors. I think if we have abnormal genetic study, they are going to refer this patient to genetic doctors and to follow with them, because the risk of future pregnancy with unbalanced chromosomal complement, family chromosomal study need to go all the part of the first degree familia, proceeding for further natural pregnancies or without prenatal. Yes, now.
Could you please raise your voice, please, a little bit?
Okay.
Thank you.
Okay, كده واضح؟ Hello?
Awesome. Hello? Awesome. Continue.
Okay. About genetic material. Okay. If patient she had any abnormal chromosomal analysis, we are going to send here to genetic doctors, and from there they are going to study all the family, and they are proceeding with natural pregnancy or with prenatal diagnosis test. Okay, we have pre-implantation genetic diagnosis or IVF. This patient for translocation carrier. This will be done by genetic doctors with IVF doctors. And for translocation carrier, be aware of financial cost if you want to do that, because pre-implantation genetic diagnosis, the IVF, it costs the patient or the parent or the family, and need to be aware of that. Higher 60% chance of healthy live birth in future untreated pregnancy following natural conception than achieve after. You see what we said? يعني there is high pregnancy rate with patient with translocation problem without intervention with IVF or BGT. For unexplained recurrent miscarriage, does not improve live birth or BGT or IVF. يعني patient with unexplained recurrent miscarriage, no need to refer them for BGT or IVF. Treatment of doubtful causes, I said, like polycystic ovary, metformin. We have a lot of study about that. No small retrospective study. Reduction said that there is reduction in recurrent miscarriage. We can give metformin for patient with a recurrent miscarriage to reduce their polycystic ovary syndrome. Okay, euthyroid woman with high serum thyroid peroxidase antibody. This autoimmune disorder. Levothyroxine 50 microgram daily decrease miscarriage rate by 13 to 3%. Okay, preterm labor from 20 to 7%. You see, if we have patient with euthyroid, normal thyroid, okay, no high serum thyroid peroxidase antibody, we can treat her with levothyroxine, and this can decrease risk of miscarriage rate and preterm labor. Hyperprolactinemia or high galacturia is we can treat her by bromocriptine. Now bromocriptine not in use. We are going to use cabergoline because with less side effect, and it increased significant rate of successful pregnancy from 286 versus 52 without any treatment. Treatment of hyperprolactinemia and recurrent miscarriage, even in the absence of overt hypogonadism recommended. Any patient with high prolactin need to treat her with cabergoline, okay, weekly or twice per week for 1 month, and then we will see this increased pregnancy rate to 86%. Okay, treatment of unexplained recurrent miscarriage, no evidence-based treatment, because majority of them, they are get pregnancy spontaneously without any assist from the doctors. Low dose aspirin, simple and cheap, we can give it. No study proves that. And then psychological support care, or tender loving care. Just say to the patient, With counseling, every visit you do for her, what she wants, if she wants ultrasound, we will do for her. If she wants BTC monitoring, we are going to do for her. This is called tender loving care. Treatment of unexplained recurrent miscarriage, no evidence-based treatment. We can use empirically low-dose aspirin because it is simple and cheap and no side effect for that. And the important thing is psychological support, as I said, tender loving care, early and frequent repeat ultrasound if patient want, BTC monitoring, practical advice concerning lifestyle. You advise patient about lifestyle, about diet, emotional support in home, in form of counseling, clear policy for the upcoming 12 weeks and medication. Chance of lying birth is good over 50%. You see, just talking to the patient, give her tender loving care, and pregnancy chance of live birth is good over 50%. Lifestyle modification, need to counsel patient to stop smoking alcohol, to reduce coffee intake, reduction in body mass index for obese women, and for all these no randomized control trial, no, it increase live birth rate. Decrease of sperm DNA fermentations, how to decrease it? Because decrease success fertility, high it is associated with infertility or recurrent pregnancy loss. As I said, up more than 30, it is associated with infertility. Less than between 15 and 30, it's associated with recurrent pregnancy loss. Less than 15, it's associated with fertility and need to decrease. We are going to give this for refer for dermatologists. For oral antioxidant, lifestyle modification, stop smoking and weight loss, identify and treat underlying condition, okay, and consider TISA or IC or SK. Progesterone, a lot of database here. We have 4 studies. The last one, I think here, okay, this we are using it here to give 10 milligram BID oral dihydrogesterone, okay, and BTCG and HCG for dose duration for 12 weeks, and considered with high rate of live birth pregnancy. Okay, 3 or more consecutive miscarriage, you can treat with progesterone, significantly decrease miscarriage rate compared to placebo or no treatment. Okay, now this progesterone only, they said it is oral, suppository, or injection. No, the last study they said the oral is better than oral, and in one study they said oral it has more congenital fetal problem. No, this study up to now is going and not finished. 2 period miscarriage trend, but not a significant reduction in miscarriage rate. Okay, limitation of miscarriage. These 4 trials were of poor methodological quality, and we are not using it. Okay, this multi-center, double-blind, placebo, randomized control trial, vaginal suppository, you see, they are using progesterone as 400 milligram microgram progesterone in first trimester. Miscarriage did not result in significant higher live birth rate among women with history of unexplained recurrent miscarriage. Okay, mechanism of progesterone, how it affects the pregnancy. Immunomodulator actions, decreasing pro-inflammatory, increase anti-inflammatory cytokine in early pregnancy. This is the mechanism. And start 3 days after LCR, not the inhibit ovulation, continue until 10 weeks. Placenta progesterone protection fully function. Yeah, and we are going to start progesterone from 3 days after LCR. Aspirin with or without heparin, no improvement. This is the treatment of recurrent miscarriage, as I said. Insufficient evidence support the routine use of low-molecular heparin to improve pregnancy outcome in women with history of pregnancy losses. No support of use of anticoagulant in women with unexplained recurrent miscarriage. Combination of both study, combination therapy and observational study before and during pregnancy with prednisolone, dihydrogesterone, aspirin, and folate. It is this improved pregnancy rate we are going to see. In treated group, first trimester miscarriage 19 versus 63, not statistically significant. Live births rate 77 versus 35, okay, respectively, and the p-value is so low. The non-randomized design and small number of cases also limit the usefulness of this study. We are not going to use this in recurrent miscarriage treatment or unexplained pregnancy losses. HCG during early gestation may be useful in preventing miscarriage. Endogenous HCG play a critical role in the establishment of pregnancy. The evidence is equivocal and we are not using it. HMG or human menopausal gonadotrophin. Okay, observational study effective for treatment of endometrial defect in women with recurrent pregnancy losses. Mechanism: correction of luteal phase defect, stimulation of thicker endometrium, better implantation site. Clinical experience support the efficacy of this treatment. Okay, you can use it. Okay, immunotherapy, we have this, we are not using it. And IV immunoglobulin confirms this conclusion. It's expensive, serious adverse effect with transfusion reaction, anaphylactic shock, and hepatitis, and they are not using it. Interrelevant therapy, not in use, just this is for observational study or for continuous medical evaluation. Okay, in vitro study, endometrial scratching. Previously, they are using it, now not used. No, we can talk about this one. When it can do it, cycle preceding the actual treatment cycle. Before we are going to start treatment, we are going to use endometrial scratching. Type 7 days before the onset of the menstruation. It is between day 17 or 12, between day 17 and 22. Before the onset start of ovarian stimulation for IVF treatment. In follicular phase, we are of the index cycle, no benefit for that, and not on the day of OR, significant reduction in cumulative pregnancy rate. How and the result? Biopsy scratch, ممكن hysteroscopy, ممكن DNC biopsy. Cumulative pregnancy rate as high as biopsy scratches as opposite to hysteroscopy. It's so strange. I review that and it's written like that. If you take a scratch by biopsy, DNC biopsy, it has a success rate of cumulative pregnancy rate than by hysteroscopy. I don't know, it depends on the experience of the surgeon or the other thing I don't know. When we are using it when there is repeat implantation failure, there is endometrial problems, neurological problems, okay? Increase both live birth rate or cumulative pregnancy rate. Or there is an infertility or unexplained recurrent miscarriage. Endometrial scratching when XC and BGD, pre-implantation genetic diagnosis, evidence is lacking, similar result, not recommended. Okay, now we are going to conclude. We talk about definitions, about causes, about evaluation and investigation, treatment, and now we are going to conclude. Investigation after 2 or 3 consecutive miscarriage, we are going to do PET ultrasound, CCG, or sonohysterography. These simple investigations: TSH, Brucella immunoglobulin, antiphospholipid antibody, factor V reading, factor V gene mutation, and protein S. If the above examination, we have the 5 main things, we are doing it first, and then we are proceeding to other. Okay, if the above examination are normal, karyotype of conception of abortus, we'll do it. If it is unbalanced translocation or structural chromosomal abnormality, we are going to screen for parents karyotype. Treatment depends on the cause. Which cause, and we are going to do the cause. Uterine problems, we are treat the uterine problem. Cervical, we are going to treat cervical problem. Uterine septum, submucous fibroid, severe intrauterine incision, hysteroscopic surgery for experienced person. Okay, cervical insufficiency, we are going with cervical cerclage. Some people, they said they give progesterone. No, they found in recurrent pregnancy loss in the second trimester, cervical cerclage is better than progesterone. Progesterone injection or vaginal or oral, it's the same. Subclinical hypothyroidism, okay, this is important, we need to treat it. Procella, need to treat it. Antiphospholipid syndrome, we'll treat it with low-dose plus low molecular weight heparin. Inherited thrombophilia, we are treating it only with heparin. Okay, we have to differentiate between antiphospholipid syndrome and inherited thrombophilia. Karyotypic abnormality, we refer the patient to genetics and then we do for them pre-genetic diagnosis, screening, or IVF. Treatment of doubtful causes, treatment of unexplained miscarriage, we said no evidence for or no good evidence for the treatment of unexplained miscarriages. Now we can hear from you and thank you.
Thank you, Doctor.
Thank you.
We can take all the questions and the all questions and inquiries to the box Q&A. Okay, please go directly ask the questions to the Dr. Hamid. The box Q&A, please.
Okay, now.
You can read the first question, Doctor.
Okay, first question. I don't know. First, is there pre-test for what I don't know? Is asking Dr. Mohammed Dipsy.
He asked me in third slide about the torch, I think.
Torch is not recommended. Torch is not recommended for the treatment and not recommended for testing in recurrent miscarriage. We are screening for specific infections, Procella and bacterial vaginosis. Some we can screen for toxoplasmosis, Chlamydia trachomatis, okay, and the others you see in the third one. Okay, and Dr. Mohammed, arcuate uterus need any surgical intervention? Arcuate uterus is not, yes, if it is arcuate uterus, no need surgical intervention. Yes, we can treat the patient without any surgical arcuate because it is slightly dimpling in the fundus and no treatment for that. We are treating septum or bicoordinate uterus. Okay. This Mohammed Dipsy today he's starting with me. I don't know why. When to start investigation? When to start investigation? Should wait for 3 consecutive miscarriage? It depends, you see, on definitions. I said American definitions. They said from 2 consecutive miscarriage you start. RCOG they said if there is 3 consecutive miscarriage, after that you start investigation for the patient. Okay. Cut-off level of hormone profile for polycystic ovary. Today, Mohammed Dipsy, he's working again, I don't know. Cut-off level for hormonal profile for polycystic ovarian syndrome. This depends. Polycystic ovarian syndrome, it is criteria to diagnose it, you see. It diagnosed it by Rotterdam criteria, and Rotterdam criteria, there is clinical sign, there is laboratory sign, you see, and there is ultrasound sign. If you found it abnormal level, it is according to the laboratory finding. It will come to you, the normal and abnormal finding. No, you must diagnose polycystic ovary. You have 2 findings from the 3 criteria: ultrasound finding, a laboratory finding, or clinical finding. Okay, let's see. Ibtihal. It is recommended to do screening for bacterial vaginosis for each pregnant. We said high-risk pregnancy. Any patient with 2nd trimester miscarriage or recurrent preterm labor, we are doing bacterial vaginosis. We are talking swab for that to treat that. Okay. Okay.
I have a question for you, Doc.
Okay.
Okay. What about the variabilities of beta HCG curve in recurrent
miscarriage?
Yeah.
Okay. Beta HCG has nothing to do here. We are treat recurrent miscarriage by beta HCG. No proof for that. Because recurrent pregnancy loss, we have definitive pregnancy. Okay, it is not pregnancy of one location, and it is not ectopic pregnancy to follow beta HCG curve. Well, treatment, yes, You can treat by BTCG. No evidence to prove that BTCG treatment improve live birth pregnancy. Okay. I hope I answered the question. I don't know.
Yeah, I got it. Okay, we have Dr. Weil. I think you want to share something with us.
Okay.
It's yours, Dr. Weil.
Hello, assalamu alaikum. Are you hearing me?
Yeah,
yes,
very
yes,
well.
Yeah.
Go ahead.
Yes. Firstly, I would like to thank Dr. Hamid Tahir for this nice informative lecture and about this which very important topic which usually facing in our department, in our clinic, daily presentation of these cases. Thanks a lot for his nice informative lecture. Also, I would like to thank Ustaz Umar Salman and Ustaz Tariq Aziz for their giving us this chance of these lectures, and we would like to waiting for their help also for other lectures, and thanks a lot also for our administration for providing this us this chance through the academic affairs. Thanks a lot for you.
Thank you, boss.
Yeah, believe me, we are here for you. We are here for you, for everyone here.
Thanks a lot.
You
can catch us anytime. Just ring a bell, and you're gonna catch us. No worries.
Okay. Thank you very much.
Thank you for everyone.
Okay, this is a time for grateful for Dr. Hamid. Thank you very much, Dr. Hamid.
Thank you very well.
I hope we're gonna see you next time.
Yeah. Always I'm ready to
no worries. This is a thankful and grateful certificate from our department for you.
Thank you. Thank you for you. Thank you for you and for Umar Suleimani. I know him for a long time since King Faisal Hospital, old one.
Yeah.
Thank you for all. I think all they benefit from that, and we are ready to answer any questions through my emails, through Facebook, through Twitters, everything. I'm ready.
All right. Thank you very much.
We
have next Sunday a new course with a new topic. It's about the leadership and self-development with Dr. Ibrahim Nami. He's gonna be with us next Sunday. Don't miss this course, please. All right. And one more thing here about the percentage of the attendance should be 85% to get the certificate. All right. We're gonna count out from the Zoom program. We programmed already the name and the username, and the total duration should be above of 85% to get the certificate. And if you have any inquiries or any questions, please take a capture from this barcode and you can ask anything you want. We are here for you. And for our colleagues, they can direct go to the tickets if they have any problems and anything from IRADA platform. Please go to the tickets and support, technical support, to ask anything. Thank you. All courses we provide in broadcasting, it's available in platform of IRADA and also on YouTube. It's all available. Please, if you need to go on and watch it again, you can find it in two platforms, IRADA and YouTube. Thank you very much.
Thank you.
Welcome. See you soon. Thank you very much.
Thank you.
Thank you very much.